Elisse currently studies at the public health at UC Davis and is interested in drug policy reform, harm reduction, and psychedelic research. Elisse took interest in the therapeutic potential of psychedelics after working in the medical cannabis industry and completed the following study on the risk profile of psilocybin while studying global health or global disease biology. She also founded the UC Davis Psychedelic Club and participated in the Decriminalize Later and Decriminalize Psilocybin campaigns in California. And so with that, Elisse, please take it away. Oh, by the way, don't forget to unmute yourself.
Sorry, can everybody see my screen? All right, I'm Elisse. I completed this assessment of the risk profile of psilocybin to complete my undergrad degree in global disease biology in 2019. So here we go. There's with my screen. Okay, here we go. There's a little bit of mushroom humor for you guys who know what happened in Denver last year. And if not, we will get to that in just a second. So psilocybin is found in over 200 species of Basidiomycota mushrooms. There's evidence dating psilocybin use between 6,000 to 9,000 BCE, showing what appears to be humans consuming mushrooms in archaeological carvings. There's also written evidence documenting ceremonial use in Central and South America within the past 2,000 years. Currently, it's a Schedule I controlled substance in the US, illegal under all circumstances. It was first isolated and studied in a laboratory by Albert Hofmann in 1958. Some of you guys might know that Albert Hofmann is also the Swiss scientist that accidentally discovered LSD. Despite the legal status, psilocybin has been currently studied for therapeutic potential within the last 20 years. It's been investigated for end-of-life anxiety, depression, OCD, substance abuse disorder, and PTSD. And in the past year, Denver became the first city in the US to decriminalize psilocybin in May. Following that, Oakland voted to decriminalize all natural psychedelics later that month. And a lot of other cities and states are attempting to do the same, so we'll see how successful they are in the following years. My study goals were to identify common risks associated with use of psilocybin, distinguish between the risks of clinical trials versus recreational use, compare the risk profile of psilocybin to other drugs of various legal status, determine recent trends in psilocybin use, and explore the possibility of rescheduling based on these risks in comparison to other drugs. I decided to perform a hybrid literature review and meta-analysis study. So for those of you who aren't familiar with types of studies, a literature review is an analysis and a discussion of current research, mostly focusing on recent clinical studies. It summarizes what we know about a topic, but can be used to find patterns of data and bring up questions for future research. And a meta-analysis is more quantitative, and it evaluates data from sources like clinical trials, population surveys, and public health databases. And so for my literature review, I did include clinical studies, case studies, surveys, and some books. My inclusion criteria, I wanted to focus on human studies only and exclude animal and cell line studies. I focused on titles that were published within the past, very limited exceptions. All of the clinical trials I included were within the last 20 years, but I did include some books that were a bit older than that, focusing on the history of human use. I wanted to focus on single substance exposures, which is psilocybin not in combination with other drugs. I excluded use of it in combination with other substances. And for my clinical trials, I did include data on healthy and non-healthy participants because a lot of them did investigate the use of it to treat certain conditions. And I did want to exclude anecdotal evidence from my literature review, although I did use some of it in my meta-analysis. And I also included some very limited pharmacological data on LSD, which has a very similar action at serotonin 5-HT2A binding subtypes or subsites, but I did exclude all data on the psychological effects of other psychedelics. My final titles reviewed included 28 clinical trials, surveys, population studies, case studies, meta-analyses, literature reviews, and books. And some of them did fall out of the initial inclusion criteria, but I did include them because they had some relevant information and because of the limited nature of my limitations included the legal status of psilocybin, which places very heavy restrictions on research. It's very hard for researchers who want to run a clinical trial to get a DEA license to investigate a Schedule I substance. There was a lot of limited research, especially clinical studies. There is some negative social stigma associated with drug use, which can introduce bias, especially when it comes to surveys and anecdotal data, because a lot of people aren't particularly honest when it comes to illegal drug use. And one big problem with clinical trials is blinding of participants and researchers. It's very easy to see who got the psilocybin versus who got the placebo, unfortunately. And clinical use doesn't necessarily reflect the same risks with recreational use at home. My literature review findings, I read the 28 titles and looked for specific adverse effects of psilocybin as well as the risk factors that were associated with them. And the ones that popped up multiple times were anxiety, increased blood pressure and heart rate, headache, and impaired motor function. All of these adverse effects were short-lived and dependent on how heavy the dose was that was administered. No long-term adverse effects or deaths resulted from the clinical trials. There were a couple participants that had some persisting anxiety, but this was resolved with a little bit of psychotherapy. There was one case study that revealed a death indirectly associated with recreational use, and one that revealed HPPD, which is a condition where a psychedelic user experiences long-term visual or hearing changes, such as visual snow or tinnitus. It seems to be pretty rare, but has been documented in the literature. And in the case of both of those two adverse effects, both of them were males of age 18 and illegally using psilocybin. One of them had a family history of mental illness and suicide. So here is the common risk factors I found. The most common one was high dose, and followed by prior history of mental illness, combined use with other drugs, possible use of car, bicycle, motor vehicle under the influence. And then at the bottom, we have history of migraines or headaches and substance abuse disorder, which only appeared once, but seemed to be associated with pretty severe consequences, so I did include them. And here we have common adverse effects that I saw multiple times in the literature. Most common one was anxiety, which was temporary and went away while the psilocybin wore off. And increased blood pressure and heart rate and headache seemed to be pretty common. There was only one death, and it was associated with illegal use. So on to my meta-analysis. What we're looking at here is data from the American Association of Poison Control Centers. There are 55 poison control centers serving over 333 million Americans. And all of this data comes from 2017. It refers to calls related to use of each of these drugs by themselves and not in combination with other substances. So you can see on this axis, there are percent of single exposures, which is individual reports of use of one drug, not in combination with other drugs, that resulted in death. The deaths were confirmed via direct reporting by hospitals, medical examiners, and media in some cases. And then on the other axis, you see percent of single exposures that resulted in treatment at a healthcare facility. That includes the emergency room, urgent care, and outpatient clinics. My goal was to compare these two variables to discover which drugs psilocybin fell closest to. And you can see psilocybin is number 77 right here in this cluster. And the drugs that it was most comparable to were benzodiazepines, which were Schedule 4, cannabis, buprenorphine, which I believe is Schedule 2 and used to treat pain and opioid use disorder. You can see some drugs such as meth have a very high rate of death and treatment at a healthcare facility. And some of the other psychedelics you can see have very low rates of death, but still have high rates of healthcare facility treatment, like in proportion to the deaths. And there are some possible confounding variables here. So these exposures were self-reported by callers. So maybe there is a little bit of recall bias, like they couldn't remember taking another drug with it. Or maybe they weren't being completely honest because of fear of legal consequences. The deaths are not only direct, but indirect deaths. So we don't know if these drugs resulted solely in the death or if it was related to other factors. And another possible confounder is some of these substances could have been contaminated with others. Like we see cocaine right here at 43 is a pretty high death rate, but there have been reports of cocaine being laced with fentanyl in recent years, for example. I also wanted to explore additional data for specific substances from 2012 to 2017 just to see what trends in use were over these 6 years. So I compared psilocybin, cannabis, heroin, LSD, and alcohol. And these are the number of calls for each of these substances over the 6-year period. So for psilocybin, you can see there was a slight decrease, but otherwise steady rates. And LSD was very similar. And we don't necessarily know if this reflects decreased use of psilocybin, or maybe people took it just as frequently or more, but called poison control centers less often. And for healthcare facility cases, we can see that psilocybin and LSD were also somewhat steady. Psilocybin healthcare facility cases associated with poison control calls did go down a bit, and LSD did go up a little bit. We can see some pretty steady increases for cannabis and heroin over the 6-year period, which I thought was interesting. Maybe the cannabis could be attributed to legalization in a bunch of states, like people are finally having access to high potency edibles and concentrates. And for heroin, maybe the hospitalizations are up due to the opioid crisis. But again, we have to ask about potential bias and confounding factors here, just as we did with the other graph of poison control data. And here we can see the percentages of single exposures resulting in deaths for each of these 5 substances. And psilocybin had the lowest death rates for the 6-year period. Sorry. And again, in comparison to the deaths, the visits to healthcare facilities were very high for both psilocybin and LSD in particular. So I started to wonder why that could be, and that kind of shaped the rest of my meta-analysis. I did analyze global drug survey data next. The global drug survey is given annually in 10 languages to 50 countries. It's considered the largest and most timely source of data on drug use practices and trends. So in 2017, over 115,000 people responded from 50 countries. About a quarter of them reported life. Of the past year users, only 17 people required emergency medical treatment under the influence. One thing that I thought was interesting was that some of these people required medical treatment because they had unintentionally consumed toxic species of mushrooms that they had misidentified as psilocybin mushrooms. But the Global Drug Survey found that mushrooms were the least likely of all drugs included in 2017 to result in hospitalization or death. And some additional data came from a small subset of people who use psilocybin and LSD. I think there were about 5,600 total, and they found that users of these 2 drugs were the most likely to practice harm reduction prior to use, such as avoiding use while depressed or anxious, not driving or bicycling under the influence, taking lower doses, and avoiding combinations with other drugs. I did use some anecdotal data from Arrowhead, which is an anonymous trip report database, just to explore potential reasons people visited the hospital. So I analyzed over 2,500 trip reports, just skimming them for references to hospitalization or emergency healthcare treatment. I did not find any fatalities that were reported. And among these 2,577 trip reports, 38 people required medical treatment after taking mushrooms alone, 45 after combining them with other drugs. Common reasons people went to the hospital were anxiety, the irrational fear that they were dying, or temporary psychosis and confusion. And in the last case, this usually resolved itself after the mushrooms wore off. The common risk factors were high dose, young age, and lack of planning ahead of trip. Common drugs taken alongside mushrooms were cannabis, alcohol, MDMA, and Syrian rue, which is a plant that is sometimes used to potentiate mushrooms or make DMT orally active. One thing I did notice that was interesting was antidepressants and mood stabilizers combined with mushrooms were a common combination that resulted in seizures. And cannabis and alcohol were the most likely combination with mushrooms to result in anxiety or psychosis. The next thing I analyzed was toxicology data. So most of the median lethal dose data was done on animal models, generally rats or mice, just because of dose in humans. The LD50, the median lethal dose, is the dose of a drug that is toxic or lethal to half of the study population. And the safety index, which is often estimated and based on human data, is the non-toxic dose that is divided over the therapeutic or recreational dose. And for the highest possible non-toxic dose, that's usually the dose that results in undesired side effects such as nausea or seizures. And for the therapeutic dose, when we're talking about recreational drugs, this would be like the average recreational dose that people take, such as 3.5 grams of mushrooms or 100 micrograms of LSD. And for both of these variables, the higher the number, generally the safer the drug in terms of toxicology. And I found that psilocybin was the least toxic drug on both of these variables. It had the highest median lethal dose and the safety index. So my toxicology data does support the data I took from poison control centers. And here you can see the safety index for certain drugs. Remember that the higher the number, the safer the drug. So at the top you have psilocybin, THC, and LSD. And at the bottom you have the more dangerous drugs such as heroin, alcohol, and methamphetamine. One thing I think is kind of interesting as a public health student, that alcohol is the third leading preventable cause of death in the US right now. So my conclusion was that the risks are generally minor and short term and limited to the duration of adverse outcomes are very rare. Common risks are anxiety, confusion, impaired motor function, increased heart rate and blood pressure, headache and nausea. Common risk factors, high dose, bad set and setting, prior mental illness, combinations of mushrooms with other drugs, and driving while under the influence. And emergency healthcare facility treatment remains high relative to the death and long-term adverse outcome rate. Potential causes, anxiety or confusion, fear of potential drug interaction, and possibly the accidental consumption of the wrong type of mushrooms. As far as implications for future research go, psilocybin is closest to current Schedule 3 and 4 drugs in terms of the risk variables that I chose to analyze. The risks of recreational use do seem to vary widely from clinical trial risks. So this is very important for future research and decriminalization campaigns to take into account. There was a lack of research on microdosing, drug combinations, and potential psychoactive alkaloids other than psilocybin and mushrooms. These could be really interesting research topics for the future. And for me as a public health student, I think one interesting thing I noticed was there was a lack of intermediate crisis resources for psychedelic users experiencing temporary anxiety or distress. A lot of the current harm reduction resources focus on overdose prevention and addiction treatment, and occasional non-addicted drug users are an underserved population. There are some limited resources, such as Arrowhead, which I had previously mentioned. There's Dance Safe, which is an organization that provides harm reduction services at music events and festivals. And there's TripSit, which is an online chat for people having bad trips, although anyone that's taken psychedelics probably has an idea of how hard it is to find a website and type into a chat box when you're having a bad trip. And with psychedelic use on the rise in the US, it's questionable whether these resources are actually going to be sufficient in the following years. So I'd like to thank my friends and family. In particular, I want to thank my friend Matt Fisher, who's a clinical pharmacist, who's kind of been an informal mentor for me for my career. I want to thank the MAPS Journal Club for allowing me to give this presentation. I want to thank my academic advisor, Dr. Neil McRoberts, for giving me guidance when I was feeling in over my head, and Dr. Dave Rizzo, who also gave me guidance and let me borrow his antique copy of The Wondrous Mushroom by R. Gardner Wasson. I want to thank the members of my MPH cohort who are taking time out of their schedules to watch this presentation, and all the current psychedelic researchers who are reviving this field and making it possible to possibly turn psychedelics into medicine one day. So, any questions?
Awesome. Thank you so much, Elise. That was really great. Yeah, so I'll read off some of the questions. I don't know if we'll be able to get through all of them because there are quite a few, but I will, let's try our best here. So this first question is from Robert, and he's asking, is there any evidence that diet can mitigate the physical risks associated with use? So for example, in a lot of forums, there seems to be a consensus that fasting in the hours leading up to a trip has been beneficial in preventing nausea. Also, many people claim that eating a clean plant-focused diet in the days leading up to the experience can enhance the trip and provide a smoother experience overall. Did you come across any data or findings related to that?
Not formally, but I think that this is an interesting topic for future research for sure. Like fasting could probably strengthen the effects a bit, which could maybe be a risk factor, but at the same time, it could prevent nausea or vomiting, which is also a risk factor for having a bad experience.
Awesome, thank you. Then this next question is from Michael. Is there any observed, or do you know of any observed increase in poison control calls in Denver since legalization?
I'm not sure because at the time I did this study, the most recent data I had was from 2017. So I think this year we will see some data released for 2019, and it might be interesting to see like whether psilocybin calls did increase after the decriminalization campaigns. Unfortunately, I didn't have access to data by specific geographic area. So I'm not sure about like looking at data from Denver in particular. I mean, it might be available if you requested it.
Awesome, we'll have to stay tuned for that one. This next question is from Matt. He says, I'm guessing no based on number of studies, but were you able to do any heterogeneity analysis?
I'm sorry, could you define heterogeneity analysis?
It's like kind of looking at variability and like different outcomes based on the studies that you used. If you don't know, that's okay. You can just say you don't know as well.
I think it would be very hard with the limited amount of clinical trials out currently.
Definitely.
Like the smaller the studies you have, like the less reliable the results are going to be. But maybe within the following years, we will get some more studies and that would be possible.
Perfect. This one's from Kate. She says, can you tell us any information about the participant demographics within the studies that you looked at? So things like age, ethnicity, gender.
I think for most of the studies, they did have some slightly strict like requirements. I think they did try to have about an equal number of males and females in the study, and mostly they were adults, like I think between the ages of 30 to 50. But the requirements were that for the most part, participants could not have a prior history of substance abuse unless they were investigating treatment of substance abuse with psilocybin. And I think that they couldn't have a prior or a family history of suicide or mental illness unless they were investigating the use of it to treat anxiety or depression.
Awesome, thank you. And we'll finish up with just this final question. Can any distinctions be made between synthetic psilocybin and the whole mushroom biomass? So were you able to look at any difference in studies that was using a synthetic versus whole mushroom?
So this is actually a very interesting question, and it's one of the things that I thought would be an interesting topic for future research studies, because in the clinical trials, they do use synthetic psilocybin. And in a lot of the anecdotal data I gathered from Arrowhead, it was just normal whole mushrooms that people took. And we are discovering that there are psychoactive alkaloids besides psilocybin in mushrooms. I think Paul Stamets is currently doing some research on that. So hopefully we will find out in following years.
Awesome. Well, thank you again, Elisse. That was super, super interesting. And thanks for taking the time to stay and answer all the questions from the audience as well.
Thank you for giving me this opportunity.